Good morning. Hi, welcome. My name is Callie Boyer. I'm the Director of Marketing for Promises. We are here at another month for PBHU. We've been doing this for over 2 years now, every month offering free webinars and free CE credits to clinicians. So we're glad that you found us if it's your first time, and welcome back if you've been here before. I recognize a lot of names in the chat, so we're glad you're here again. Today we are with Andrea Deodas and Amanda Owens. They are from our Washburn House facility up in Massachusetts. So they're going to be speaking to us today. Their presentation is called Run Towards the Noise, Acute Care Professionals' Response to Crisis Interventions. So if you are here today as an acute care professional, we're glad that you're here because I think this will be very, very helpful to you. So if you want to go to the next slide, I'll introduce these two. Andrea.
Yes, got it.
Thank you. Okay, so our first presenter, Andrea, is I am introducing Promises. Just kidding.
Yeah, I was gonna
I
say.
switched it up myself. Okay, so Promises Behavioral Health. We are a network of treatment centers across the country. As you can see, we're in Texas, Tennessee, Georgia, Pennsylvania, and Massachusetts. So every facility, what we have in common is our dedication to the clinical curriculum that we offer. So it's at least 30 days of unique healing care and process. We have family programs, we have inpatient, outpatient, telehealth opportunities. At Washburn House, Massachusetts, they have the longest stay possible for in Massachusetts. I'm sure Andrea can speak to that more later, but it's pretty amazing. Down in Tennessee with equine therapy, a sexual recovery program. Pennsylvania just got named in 2025 one of the best treatment centers in the country. Promises Atlanta is one of our new locations, and so is Promises Dallas Fort Worth. So and then Texas Promises Brazos Valley was one of the very first mental health dedicated residential programs in Texas. And the Right Step Houston has been open with us since 1990. So all these treatment centers, they offer their own unique like healing space for folks, but just know that the clinical program is the same. And all of our professionals that you've seen here speaking through us are all going to be from our programs. And it's just giving you the opportunity to see what that excellence really looks like. So I'm really happy to have Andrea and Amanda here today. If you have more questions about any of these programs or you'd like to have a tour or learn more, please just send me a message in the chat. You can put it to Callie Boyer there, and I will happy to I'll send you anything that you need. And you can also send an email to pbhu@promises.com. Anytime during the webinar that you have questions about our programs, I can help you out there as well. Okay, you can go to the next slide. Okay, Amanda. She's a licensed clinical social worker with over a decade of experience in behavioral health and addiction treatment. She oversees clinical operations across both stabilization and acute treatment services, ensuring those high standards of care throughout. She's held leadership roles in both inpatient and outpatient settings and has a strong clinical foundation, working directly with individuals, couples, and groups. Amanda is trained in evidence-based approaches like CBT, DBT, and trauma-informed care, which we will learn more about today, and is deeply committed to delivering passionate, high-quality treatment. She's also continuing her leadership growth through doctoral studies in healthcare administration. You can go to the next slide, please. Andrea, I'm excited to introduce Andrea. She serves as the executive director at Washburn House and brings over 2 decades of leadership experience in behavioral healthcare and community health. She has a strong clinical and administrative background with deep expertise in areas like healthcare compliance, program development, and quality management. Andrea is dedicated highly passionate about building on Washburn House's longstanding legacy and advancing high-quality, evidence-based care. I think if someone's going to work at Washburn House, both of these two ladies are a testament to the passion that they have in that space. So, what's especially meaningful is that also Andrea is committed to recovery that is not just professional, but it's deeply personal. So she brings that perspective into her leadership every day with a focus on compassion, community partnership, and truly patient-centered care. Thank you both. I'm really glad that you are here. Okay, so let's get into the webinar. Just to answer a quick question in the chat. No, your camera is not on, and you're going to also be muted this whole time. That's just to make sure we can all be present during the webinar today. And that's also to speak to the chat and the Q&A boxes. So the chat at the bottom, you all are already know where that is. Those are going to be for questions or feedback for me. That might be like technology, CE questions, webinar functions, anything that just needs to be answered can come to me there. Also, Andrea and Amanda may prompt you to give some feedback on a slide that they're speaking to, and you can put anything that goes about that into the chat. So just know that we do want to keep the chat down to a minimum, so try to hold off on like long side conversations. Now, the Q&A at the bottom, I'm hoping you all can see that. Does everyone see a Q&A box at the bottom, kind of next to where you saw the chat box? Yes. Okay, great. Thank you. In that Q&A box, that's where your questions are going to be going to Andrea and Amanda to answer during the break and at the end for Q&A. So try to keep those to just questions that are regarding the actual content so they can answer your questions. We just want to keep those separate. Okay, awesome. You can go to the next slide. Next month with PBHU, we have from confrontation to collaboration, motivational interviewing and action. Darilyn Green is from the Right Step Houston. She's wonderful. She's did one of our family webinars a few months ago. So I highly recommend that one if you're interested in learning more about motivational interviewing. Same as always, it's the fourth Friday of the month, 9 to 11. And I will drop a registration link to that in the chat when I'm done here. You can go to the next one. As I just mentioned, we do offer family webinars now. So on the second Tuesday of the month, these are not for CE credit. So just know that if you'd like to join, these is just going to be more learning about kind of what families can be thinking about when their loved ones are in treatment. So we offer these to all of our families that are in treatment with promises, but it is open to anyone. So if you are a clinician or a therapist here today and have a family member that might just benefit from learning about codependency or anything of those treatment tools, that's where you can come. And so you can either sign up at this QR code could take you there, or you could just go to familyservices@promises.com and I can send you more information. I'll drop a registration link in the chat just so you can be sure to have it. But those are growing and it's the second Tuesday of the month, 5 to 6 p.m. Central. And everyone is welcome. Okay, you can go to the next slide. Okay, I get to pass this back to you, ladies. Thank you for being here again. And I will be in the chat if y'all need me. Thank you.
Thank you so much, Callie. Appreciate your time with us today or this morning, wherever everybody is. Super excited to see that we have an amazing, diverse group of individuals who've decided to join us today. Well, welcome. Again, my name's Andrea and my counterpart here is Amanda. We're looking forward to kind of guiding the next couple hours with you all on this amazing journey to talk about how we are going to respond to crisis intervention. And I'm going to make a few assumptions about the group automatically, that you are somebody who is either a professional in the helping profession or a paraprofessional or somebody who is interested or connected to an individual in the community receiving services or somebody who has lived experience themselves. I hope that you find during our presentation today that you'll see many of the aspects that we draw from are going to be paralleled processes. Not only are we going to provide some education and tools, but these are things that we can use on a day-to-day to help support ourselves through the helping profession. And I'll get into more of the weeds with Amanda in a little bit from now. So again, good morning and thank you all. Shout out to the person who's from Alaska. Saw that. So let's get this kicked off. I don't have any disclosures to share, no conflicts of interest. This topic has been presented has not been presented to any other meeting or outside the industry exactly in its current state. Okay. It was previously presented at a former symposium of addictive disorders, but not again in its current state. So a little bit different. Today, we're going to talk about, or hopefully you will walk away learning a bit about demonstrating examples of fight, fright, flight, or freeze responses, strategies to support clinician self-care best practices, hopefully walk away with gaining some skills and mindfulness, ways to reduce vicarious trauma, through techniques like deep breathing and body scanning. We're going to discuss SAMHSA. Amanda will go into that topic regarding the underpinnings of trauma-informed care principles. And we'll get into the weeds of some neurobiology and the science of substance use, trauma, and behavioral health care, landing on how we respond to clients or patients with compassion. We'll go over some of the basic definitions and introduce kind of a mix of evidence-based practices and emerging best practices in the industry, and define, again, some of those basic principles of trauma, traumatic events, post-traumatic stress, etc. We're also going to talk about our personal experiences here today. I will do some sharing. Amanda will do some sharing. We hope to elicit a lot of good chatter in the chat and the Q&A section, where we are going to call upon you as the audience, as the learner, to share some of your experiences with us and have an experiential point of view as we move through some of these topics. Discuss more about the neuroscience of trauma and resilience and the resilient brain. What are the implications to the healthcare system, and how trauma-informed care responses can really support our treatment modalities, okay? Just as an overview. So why are we here? I'm going to start off with Amanda discussing her why. This is something we believe to be particularly important, not only as practitioners ourselves, but as people who are helping to support other practitioners and our community, is understanding a deep commitment to the why. And a variation of that would be, what is the interest in this topic, right, Amanda? So why are you here and what's the interest?
Yeah. So I am a veteran and I served in the military for about 10 years. And while I was in the military, I was also getting my bachelor's degree, as many of us in the military do, utilizing that education benefit. And one of the things that really got my goat a little bit, grinds my gears, is that while I was working on my bachelor's in psychology, we were also doing a lot of resiliency training in the military pre-deployment. And there was a lot of chatter at that point in time. Keep in mind, this was years ago. There was a lot of chatter at that point in time how resiliency training wasn't going to be beneficial for the troops. And that very much was upsetting to hear from me, because not only was I training in the world of psychology and be really developing an interest in working with veterans with trauma, but I was also experiencing those resiliency trainings pre-deployment. So I had kind of both sides of the fence, as it were. And that was disheartening to think that there were people out there who were, in what I was hoping would be my community of psychological providers that were, not hopeful for the troops that were receiving those resiliency trainings. So that was my why, and why I wanted to get more into how to not just build resiliency, but also deal with the trauma that can happen, after the fact. Resiliency is key in really preventing a lot of the symptoms of PTSD. But when we're not able to get there, right, we want to be able to also treat the individuals who are experiencing PTSD in a way that is most beneficial for them. So that's my why.
Thank you. I also resonate a bit with that why, and I see some hearts coming up. Appreciate those responses. Again, making assumptions about everybody who's here. If we're in the helping profession or circling it, there's probably something in our lives that have led us towards this calling, this passion. I am similar in that way. Admittedly, not a veteran. Thank you again for your services, Amanda, but have lived life experiences around family and friends, my community, and have built up through those experiences this innate organic ability, responsibility to serve, right? So that I feel as though is a similarity that we probably all share. I've spent half of my career learning that service and participating in different ways that not only feed the community, but also do an internal feeding. And that's the parallel system that we're going to talk through today. So I spent half of the career in hospitals, high acute settings, psychiatric emergency settings, well over 15 years. And something that I learned along the way is the conditioning around it. So again, speaking from personal experience, working in hospital settings, working in an acute psychiatric hospital, I remember when being a milieu therapist, and whenever there was a psychiatric emergency or a medical emergency or a code, there would be a buzzer that would go off. And I voluntarily, of course, walked into that profession and participated in the response to those buzzers, where I am running towards what most people with a normal brain, which we'll talk about later, into the noise, into the traumatic event, like running towards whatever crisis that would be. And hence the title for today, like running towards that noise. And I found myself being conditioned over and over and over again. And as I continued to respond, not only in the career, but in my personal life to traumatic events, exposure to traumatic events, being that person who's called upon time and time again, that the feeling of needing to jump and fight into it decreased over time. That feeling of calmness began to set in. And this is where I observed the shift from being a fighter to being a resilient person in different traumatic experiences and really exploring this topic. So transitioning from inpatient work and even working with minimum and maximum security prisons where I felt very comfortable and confident, whereas maybe the typical person would not feel comfortable and confident walking into those situations. And as the observation occurred, it wasn't just me, the colleagues around me, the supervisors, right? Everybody who's involved, the clients and the patients who were observing the traumatic event or the crisis that was occurring, everybody had different levels and variations of how this event was impacting them. And that's what really turned on the brain towards this why. Okay, so my why towards this is to hopefully impact the community, provide education and resources, but also to let folks know you're not alone. And it doesn't matter at what stage in this process people are, we are a community that comes together. Similarly, some of these skills that work really well in the workplace maybe don't transition well into our personal lives where the stranger danger noise starts to dampen. Because I found myself often being the person who's helping an individual out on the side of the road if the car's broken down and I'm by myself and it's 2 a.m., right? I don't know what I'm doing at 2 a.m., but if I'm driving down the road and someone's broken down, I'm probably going to help. And so we have to be situationally aware of when these occurrences are appropriate and not, so that we are good protectors of thyself. and making sure that we know when to transition that to other people. So, all right, let's start with some definitions. Definition of trauma. So, right, trauma, we're going to focus on, for the purpose of this presentation, definition B and C, where, of course, trauma is the noun, person, place, or thing. We're focused on disordered psychiatric behavioral states, emotional upsetness, and how it is that we're going to move through those particular traumatic events. And in each slide, you'll notice that we've put a lot of resources here at the bottom. You will have access to the slides and all of our resources that we have pulled from for today as well. So anyway, just want to call that out. Whereas traumatic is the adjective, right? It's that description of the nature of the event. Now, the relationship between a traumatic event and trauma is exactly that. It is the relationship. So the traumatic event is what causes the trauma. And again, we're going to focus on definition number 1 for the purposes of today's presentation. So for example, if a person is experiencing trauma after an accident versus traumatic, where the accident was the traumatic experience. So these are subtle but meaningful differences that kind of walk us through. Then there are the levels. Okay, different levels of vicarious trauma. So vicarious trauma is that secondary traumatic response. It's the secondary exposure to the event. It's not something that we are personally experiencing. It's something that we have observed. So it's the observation and the absorbing of other people's pain. And when it becomes vicarious trauma, it's where our empathy turns from that into sympathy. So maybe we are now being personally impacted by the events that are taking place, again, making assumptions about the group here in the workspace, right? And how does that work? Well, it's like throwing the pebble into the water. There's a ripple effect where the waves that are closest to the pebble are going to be largest and more vibrant and deep. And the further away we get from that pebble, the waves become a little bit less vibrant and deep. And we can talk about some examples of universal vicarious trauma, all right? I'll say universal in the sense of a recent, or excuse me, a less than recent event, but I'm assuming folks on the call may remember or have read about 9/11, right? So here's an example of different types of vicarious trauma. Going back to that pebble being thrown in the water. The folks who were involved at ground zero, right next to that pebble, deep waves, deep disturbance, deep waves. Whereas an exterior ring would have been maybe the eastern region of the US, a little bit closer to New York, but not quite. Another extension of that ring would have maybe been central US, and then a further extension, western. So here I'm talking about the proximity. So proximity levels of involvement with vicarious trauma and the exposure to whether it's personal, closest, in this particular example, 9/11, television, televised, internet, newspaper, and secondary, tertiary to that are personal relationships, of course, as an example. Well, in vicarious trauma, those levels are mild or moderate or severe. So when we think of a mild vicarious trauma exposure, we're thinking about distress, increased stress, maybe occasional fatigue or irritability. And if we transition this to the working environment, maybe it's you're having a bad moment, right? Andrea's having a bad day. She needs a cup of coffee. We don't know. But I promise you, it's the people around you who start to notice these things probably before we do, right? So that's just a quick example. A moderate level of vicarious trauma would be more chronic stress, interference with the day-to-day. Maybe there are sleep disturbances or hypervigilance or withdrawals. Again, these are things that your colleagues or people around you maybe will start to notice before you do. An example of that could be kind of coming into work late, skipping breaks, leaving early, etc. Maybe calling out sick, just feeling fatigued. Last level would be severe. Severe vicarious trauma is disabling or can be disabling in long term with significant shifts in our worldview. It's deeply profound, deep cynicism, profound burnout, as we call it. There's potential for self-sabotaging behaviors in there. And some examples of that in the workplace may be long periods of absenteeism, increased medical ailments, underperformance, blaming the client, blaming the patient, right? Or blaming coworkers. In these instances, we want to just also say that seeking support, supervision is essential. But we do experience this at varying degrees in the helping profession. So I want to call out to that because today we're talking about our vicarious trauma and how we build resilience as professionals. Okay. Bringing it to our team members and what we see in the workforce. So internal changes in staff members. Who's the front line, right? Our frontline team members are typically the counseling team. Again, getting back to that stone, getting back to the ripple, getting back to ground zero. Who's the front line for us? Clinicians, CNAs, nursing, medical, clinical case management, milieu therapists. These are the folks whose vicarious trauma is more true than the rest. Second line staff, maybe the supervisors and the managers who are supporting those frontline individuals, right? In a healthcare setting, maybe it's administration and housekeeping, still hanging around those situations, but not necessarily involved. And then a tertiary level of that would be our utilization review specialists, right? People who are reviewing the daily charts of the clients who experienced the trauma. We're reading through the case conceptualizations, where maybe it's the insurance reviewer. And then we kind of expand the rings, of course, of the vicarious trauma and look to what are the organizational impacts? What are the community impacts, regional impacts, worldwide, so on. We commonly refer to all of this as burnout. Okay, like if we're having conversations, colleague to colleague, and you're just observing, you're probably hearing people saying, I'm just a little bit crispy today, right? I'm tired. Probably hear that. It's just emotional exhaustion. This is the lay language. Less lay language would be compassion fatigue, but it is another way of us responding to and expressing our traumatic response, our stress response to traumatic events and vicarious trauma. But these are the most common terms used in our profession. And there are multiple health implications that come along with it. Okay. And these are some of examples that may be very obvious to you, and others that you may just think, oh, this is part of my day-to-day, but is it? Ask the question, but is it? So we have a list here to go through. I'm not going to read all of them. Some of the things that kind of stick out to me, though, are certainly number one, which is poor sleep. How many people chalk it up to, I had a bad night's sleep? Well, what was the cause of the bad night's sleep? It's like the iceberg. What's happening underneath that iceberg? That's just the tip of it. Maybe, thank you for the thumbs up on that. Appreciate it. Is it, are we second guessing ourselves? Are we feeling a little bit irritable? Are we overworked? Are we feeling like there's a lack of flexibility? Maybe there's situations where we're avoiding things. Maybe we're a little bit jumpy. Maybe it's the quick email response where we, in our best version of ourselves, are actually going to take the time to thoroughly respond to that email, and our less prepared version of ourselves, the ones who are kind of turning the blind eye towards the burnout and the fatigue, yeah, maybe we're sending that quick email before really thinking on it. So these are low level, I would say, health implications to just be aware of as a helping professional. Okay. Saw a lot of thumbs up in the chat. Certainly speak on that if you think so, if you think there are certainly some parallels into what I'm talking about right now and what you've experienced or others around you. Appreciate that. All right. We won't go too much into this deep dive. Amanda will talk about post-traumatic stress disorder. I am not here to say that we as healthcare professionals or paraprofessionals or interested in the field are having or experiencing or been diagnosed specifically with PTSD, but there is a thread of connectivity between vicarious trauma and post-traumatic stress disorder. But this call out specifically is just to say that this is a diagnosis, okay? And Amanda will talk about these core principles in the realm of trauma-informed care. Okay. All right. So for the purposes of this point in the presentation, let's kind of review what those symptoms or immediate reactions are. I'm sure many of you have heard this on the call, and if you haven't and this is new to you, we call it the 3 Fs, the fight, flight, or the freeze. This is your body's response system in plain language. The fight, flight, or freeze is just a natural reaction to danger. And what we are theorizing today is that over time, with practice, it is likely that the resilient brain starts to desensitize itself to the fight, flight, or freeze responses. And whether or not that is helpful, impactful, fill in the blank to you in your personal life is what we're here to help you walk through today and provide you with those tools. So there are implications that multiple experiences with vicarious trauma does increase or may increase a healthcare provider's ability to respond appropriately to fight, flight, or freeze, whether it's a healthcare individual being in harm's way, closer than others, proximity, being in high-risk situations, whether it's in or outside the work. So Question for the chat, and this is where we're going to kind of dive in here. Don't think too hard about it, but in a crisis situation, do you default to fight, flight, or freeze? And just throw the words in the chat, okay? Yeah, fight, fight. I see it. Lots of all different. Wow, excellent. Wow, it's a mix. I love that.
Mm.
Mm-hmm. Lots of fighting and fight and freeze.
I want to just take a second to acknowledge that, some people were sharing in the chat before we got to that question about their experiences of, exhaustion and feeling like, you're awake, but you're not able to do the things that you need to do because of just feeling done. And that really does speak a little bit to that freeze response as well.
Mm-hmm. I did notice that somebody put in the chat here that they're a fawner, and you'll notice that I don't go into we don't go into that necessarily here. That's kind of a new observation in the scientific community, if you will. But for those individuals, I love that. There's an intense flattery or affection to gain approval from a survivor, and that's what the fawner would be. And so we don't have enough data today to talk about how the implications of that particular response is impactful with the brain chemistry, but I appreciate that there are a few of you who did recognize that within yourself. And so thank you so much. Appreciate it. Noticed a lot of people saying that they're fighters, not surprised. Okay, going back to my own personal lived experience examples. When we see the group running towards in a safe space work setting, right? I'm going to make some assumptions again. A lot of us are going towards that noise. That would initiate the fight. This would initiate, are we among kindred spirits here? Are we doing that same response? There is no right or wrong. Right? This is all personal experience and your personal comfort level. So appreciate that. Okay. Back to the chat. We would like for you to identify a situation where you've encountered an experience that elicited the fight, flight, or freeze response. Okay. And Amanda, do you think this is best for the chat or this is best for the Q&A?
The chat.
Okay. So feel free, by all means, only disclose things that you're comfortable with. If you want to remove specifics, you can. We're going to read through a couple of them out loud here. And then if you could also, in what ways did you learn to cope with the situation? So kind of a twofold. A little synopsis of an experience that you've had where you've encountered this, and then how did you cope? Okay, I'm just going to read off the first one I see, Amanda. So thank you, by the way, for sharing in the chat. There's an individual here who shared that there was a very angry client who was yelling at them, and their way to cope with that was to remain calm. Very appropriate. Okay.
There's another one who's identifying that they go into a freeze response when other providers and that person disagree. And they've coped by, trying to find their voice without activating fight, which is very insightful. It speaks to, that level of experience that we're talking about with resiliency.
I did see in the chat an individual who did take it to an experiential moment with 9/11. Thank you for sharing that. Another individual discussed here that it's prolonged experience from disaster everywhere else. And dealing with multiple crisis appointments that occur at the same time, just working through them. Yeah, so you're kind of going into robot mode in that scenario. That's the fight. We're fighting our way through it. We're working through it. We'll talk more about the neuroresilience of the brain and what exactly is happening there. Appreciate all these responses. okay, this person expressed that they respond to crisis non-judgmental to social situations, even though their initial first response is to yell, like, no, something is wrong, but they don't. They literally just said here in the chat that they take a breath and orient to education and question rather than react emotionally. I would definitely go out on a limb here and say that those are the skill sets built by a resilient brain. And we're all going to learn those skill sets to help build resiliency. Yes, tend to remain calm and help to de-escalate others. Yes. Lots of really great examples. Appreciate the shares, everyone. Okay, let me catch up with the chat. Mobile crisis, totally different ball of wax, right? In many of my examples, I talked about having controlled crisis where the fall walls are around us. We haven't touched yet on mobile crisis teams or community.
Mm. I'm seeing one in the chat where this person had a client who was having a panic attack over the phone, and they had to stay calm and work on exercises to help calm the other person down. Very, very difficult when the person's not in front of you.
Yes, absolutely. Okay. Thank you so much, everyone, for sharing. Appreciate that. And so those are just your organic experiences. We haven't even yet gone into what we're about to dive into, which is there are evidence-based therapies out there, right, to help support trauma. And there are 5 EBTs of effective ways of treating trauma. So prolonged exposure, cognitive processing and therapy, stress, inoculation therapy, trauma-informed approaches, which Amanda's going to talk about, EMDR, and many other types of neurocognitive therapies. Lots of resources here for anybody who needs. So kicking it over to Amanda to really discuss what the underpinnings are here of a SAMHSA approach to trauma-informed care.
Thank you. So SAMHSA has a very specific approach to trauma-informed care, which is grounded in 4 specific assumptions and 6 key principles. And we're going to go through all of those. So the 4 assumptions I often think of as the 4 R's. And those really are that all people within an organization, it doesn't matter what your role is within an organization, there should be a consistency that everyone in an organization should have the basic realization about trauma and understanding how trauma will affect individuals, families, groups, etc. And in addition to having that realization, people within the organization should also be able to recognize the signs of trauma when the individuals are activated and respond to that activation in a way that doesn't re-traumatize the individual. So that can look like a lot of things, right? But one of the things that it really focuses on is that response piece. And we're going to get into that more later on. The 6 key principles, thank you, are safety, trustworthiness and transparency, peer support and mutual self-help, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. So I like to take that last principle first, because this is really key to trauma-informed care, is acknowledging that the experience of trauma is not one specific thing, right? When it comes to the diagnosis of PTSD, there are specific criteria that need to be met. Specifically, criterion A is that a person has to have a event. Doesn't really matter what the event is. It could be natural disaster, it could be a fire, it could be some type of abuse. But that event needs to have the perception that this person could die or that somebody else will die. That real or perceived threat of death is a key component to criterion A. And why I bring this up is because while a lot of people won't have an event that meets criterion A standards and will not be able to be diagnosed with PTSD, it doesn't mean that they don't have traumatic events and the responses that those traumatic events cause. So cultural, historical, and gender issues is really encompassing that there are biases in the society that we live in. There's also generational trauma that is a potential possibility for anybody and everybody. So when it comes to traumatic events, it could be that we're not talking about somebody who's had the criterion A event, but somebody who's experienced discrimination, somebody who's experienced generational trauma. You know, a great example of generational trauma is the scarcity that people experienced around the World War time, right? So there's still plenty of people in our society who will do things like reuse tea bags and tinfoil. And that is a behavior that stemmed from that scarcity. We don't want to have, any, sorry, I'm struggling for the word. We don't want to have any waste. We want to make sure that we're utilizing all of our resources to their absolute fullest extent. And that scarcity drove that need. And it does come, generationally. When you see that as a child, that the person that is raising you, your caregiver, is doing those things, then you start to develop that habit too. And then you can, in turn, pass that down to the next generation. So generationally, these behaviors that are rooted in trauma become habitual for people who've never experienced that trauma. So when we see the impact of trauma and the different behaviors, that is a key component to how trauma-informed approach really works, because it doesn't matter that they didn't have the criterion A. They're exhibiting traumatic behaviors. So that piece is really, really important to note. And it also could be indicative of that vicarious trauma that Andrea was talking about earlier, right? As providers, we could have traumatic responses based on those vicarious trauma experiences that we've had in the work that we do. So the other 5 principles here kind of go hand in hand. They all kind of weave together, right? So a trauma-informed care environment, you want to build an environment of safety. How you do that is through some of these other principles, in addition to consistency. Consistency and predictability are key components to building a safe environment. An environment that has structure and is able to have everybody in the facility understand what to expect. That predictability piece goes a long way, because if I know what's going to happen, then I can feel confident in that, right? If there is less predictability, then it creates a little bit more chaos, and the individuals in the environment no longer have that sense of safety. Trustworthiness and transparency really focuses on when we are working with clients, we want to make sure that we're doing what we say we're going to do, right? All they have is our word. So if we're not true to our word, if we're saying yes to something and not following through, we're not building trust. And when we're not building trust, we're not creating a safe environment. But when we are building trust, we are creating a safe environment. So saying yes and following through, or don't say yes, right? If you can't say yes to something, if you can't follow through on something, don't say yes. Use a different phrase. Let me get back to you. I'm not sure. Let me ask the question. And that way you're not making promises that you can't keep. The transparency piece is really about when we have to say no to something, giving the rationale, not just saying no and letting them think, oh, that person just doesn't like me very much. They don't want to help me. They don't care. Um, the assumptions that people can make can go very quickly in that direction. But if we're transparent about why we can't do a thing, then they're going to be more apt to be understanding of our position and not make those negative assumptions. Peer support and mutual self-help and empowerment, voice, and choice really, really go hand in hand. We want to empower them. We want to make sure that they're able to articulate their voice and advocate for themselves. That doesn't mean that we're going to be able to say yes to everything, right? Again, transparency. However, when we're giving them a choice where we can, that again builds trust and creates a safer environment. And when we're collaborating, we're really, really focusing on how we can meet people where they're at and get their goals achieved. Because at the end of the day, the patients that are in our care are not here to achieve our goals, they're here to achieve their goals. And we have to keep that in mind whenever we're, bringing up, hey, I'm noticing this need. We want to make sure that they're noticing that need too. We want to make sure that it's really wrapping around them in a way that they're able to help themselves. Because at the end of the day, they're not going to stay in our services forever. And we want to make sure that they have the tools to do better once they're no longer in our treatment. So one of the things that really these guiding principles informs is really the foundation of a lot of different kinds of trauma work that people can do. And because it's kind of the foundation, I'm going to pass this back over to Andrea for her next piece.
Amanda, appreciate everything. There's some great conversation going on in the chat. Just want to reflect on comment that somebody had made as you were going through the cultural, historical, gender issues. And you had brought up the example of saving the tea bags, is that we do have an individual in the chat who shared that their family member was from the Depression era and in fact did reuse that saving technology, those pieces. And some of that, I'm sure, like you had mentioned, transcends generations, those behavioral impacts.
Absolutely.
And again, just want to pull home here that while, Amanda, you're talking about trauma-informed care practices as practitioners or as people, because anybody can be trauma-informed care provider. You don't need to necessarily be a professional to be a trauma-informed care person. But these skills are transferable to ourselves as well. And it is, in fact, the osmosis of practicing these skills that we become more resilient in our own lives and resilient to be the best practitioner to show up day in, day out for our clients and our patients within our care. So I really appreciate all these parallel pieces here. Yeah, learned and taught behavior. Absolutely. Okay. All right. So we kind of did circle around this quite a bit already. The best practices for treating trauma-informed care. Just want to reiterate the parallel experience, because as we are doing these trauma-informed care approaches to treatment, our body doesn't know the difference, okay? The brain doesn't know. The brain is an ancient being. The brain does not know whether or not we are practicing or we are executing or things, okay? Whether it's a deep breathing technique that I know somebody had shared in the chat, that's one of the things that they do. We will talk about deep breathing and box breathing a little bit. Your body doesn't know the difference. So as we help to mentor and expose our individuals to these sorts of tools and techniques, we are doing it as well. Again, it's that proximity principle, similar to the vicarious trauma. So we are already being trained on the resiliency and the skills that we need to attain a higher level of resiliency within our profession and our personal lives. Again, this is like a refresher course, and for others, this is our first time learning. But basically, we all get to choose what those techniques are going to be. It is like, if you've ever been on a plane, one of the core teaching moments that the flight attendant tells you is to put on your oxygen mask before you take the time to put on somebody else's. And it's the practice of putting on the mask that we are saying today is going to help you build more resilience. It's not actually the action itself, it's the practice of it. I love how my slides go backwards, even though I want them to go forward. So let's talk about the neuroscience of the normal brain and the trauma and resilience pieces that come along with it. All right. I'm going to interchange a lot of these words with the abbreviation of the definitions. So let's talk about the primary areas of the interest focus for today, which is the amygdala, right? That primarily is the responsible portion of the brain for eliciting emotional responses. It is what helps to process memory. It's what helps us in decision making, and it's the key component to the limbic system and is essential for our survival instincts. We'll get more into the limbic system later, but what we need to know now is it's the fear part of the brain. Whereas the prefrontal cortex is more of the wide range, crucial component of understanding complex cognitive functioning. And it's known as the executive functions of the brain. It helps to shape our personalities, the way that we express ourselves, and how we moderate social behaviors. And it doesn't necessarily fully develop until your mid-20s, okay? But it's the thinking part of the brain, for lack of a better term, and we'll call it PFC today. Then we have the anterior cingulate cortex. We're going to refer to this as the ACC, and that acts as the interface between the two, between the emotion and the cognition. It's responsible for detecting errors and monitoring conflict and is our emotional regulation. It's helped keeps us in balance and in cognitive control. This is the layout. This is where all these things live, okay? Nice little map of the AAC, the prefrontal cortex, and the amygdala. This is the normal brain. So the normal brain in action is going to have moderate activation of that amygdala, a moderate activation of the PFC, and a moderate activation of the ACC. Steady, cool, and calm, the normal brain. However, those connections aren't necessarily always steady, cool, and calm together. So together in the normal brain, we see the amygdala connected to the PFC, and that connection is strong, whereas the PFC to the amygdala is weak, and the amygdala to the ACC is strong, and the ACC to the amygdala is weak. Basically, we're talking about the pathways of how this all boils down together. So if that's the normal brain, then what is the resilient brain? And is the normal brain or is the resilient brain better than the normal? Well, the ability here for the resilient brain, the neurobiology, is driven by strong top-down regulation. It's the ability to downshift. It's where the prefrontal cortex and the AAC connect to the amygdala, but it reduces our fear response. And it helps to produce emotional reactivity in a decreased way. It's our ability to kind of stop and pause. Okay. And so I know we've asked this question before about the crisis situation, and you've all discussed different ways, or thank you for participating for those of you who have, what your response mechanisms have been. But you can train this part of your brain. You can train this part of your brain through repetitive techniques, repetitive behaviors to kind of downshift and give more of that top-down command. For example, a resilient brain. Well, how do you identify them? You can't just walk around a room and say, oh, look at your brain, you have resilience. Ta-da! No, but you're going to identify those people in certain situations and places. In the event of a crisis, the person who may have the more adaptability to have honed in on these resilience pathways in their brain and have trained is typically the calmest person in the room during a crisis. This is the person who you're looking towards to maybe make a decision. It is likely that that person has a very strong, resilient neuroscience and biology to their brain. Okay. So this is what a bit of the neuroscience looks like of a resilient brain. More ACC going on. And here's how we know it's a top-down pathway. So basically, the resilient person is having an enhanced functional connectivity where there's strong negative coupling going on here. And this is kind of the opposite to the normal brain, where we have some stronger and weaker pathways in one area or another regarding the amygdala, the PFC, and the ACC. Where the prefrontal cortex and the AAC are inhibited of the amygdala activation. So the amygdala is telling us, okay, fear response, let's go, let's move. Where you built up enough strength, where the PFC and the ACC are like, no, slow down. We're going to tell you, we're going to moderize this. We're going to slow down a little bit. So it kind of helps to extinguish the threat and allows for cognitive control. So here's some examples, right? I have been unknowingly practicing this exact skill throughout my career. And it's like this. When I walk towards a crisis situation, I'm running towards the noise. I'm that person, okay? If there's a noise, I'm running towards it. If there's a code, I'm going towards it. If there's a crisis in the community, some people are running, some people are freezing. I am fighting. Here I come. Through practice and time, it is like the puzzles are floating in the air and time slows down. It is a physical feeling. It is now relatable. It is the moment where people who've experienced non-debilitating car accidents, for example, who can recoil their memory and say, I almost feel as though I saw the car accident happening in slow motion. It is that effect. When you've built these pathways to the resilient brain, it is the effect of having the ability to slow things down, almost look at it like a puzzle, and be able to build it together in real time. And to be simple about it, one of those great ways to practice this skill is like yoga. Yoga is a great way to help balance and slow down regardless as to what's going on around you. Again, getting into those deep breathing activities. But it is an example of the resilient brain. And so the normal brain will respond in a very different way. Whereas Amanda will take this one. Opposed to time slowing down for the resilient brain, the normal brain will take it to an activation state of mind.
So the reptilian brain, right? The brain stem, that ancient part of the brain that Andrea was referencing earlier, is really in control of all of your automated functions, right? And then obviously, as Andrea said earlier, that neocortex and all of its pieces is also the home of all of your conscious thought, all of your logic, right? But when our brains are activated, when we're in that survival mode, that fight, flight, freeze, the limbic system is what's taking over. Now, the limbic system is where the amygdala lives. So that's, in line with what we were just talking about. And what it tends to do, as Andrea had mentioned earlier, is that, the cortex to the amygdala connection, right, can be diminished in one direction and strengthened in another. And the more activated our limbic system is, the more we have experienced traumas, the easier it is for our amygdala to take over and our limbic system to take over. So when that happens, all of the conscious thoughts, the logic, the reason, all of that really just comes out. We're not really focusing on that. We're kind of cut off from that context that the cortex provides. What we're really, really focusing on in that moment is impulse. Everything slows down in that way, where our body is responsive only to what the amygdala is telling us in that moment, what that limbic system is telling us in that moment. Go ahead, Andrea.
Thank you. I was responding to some folks in the chat.
Gotcha.
Thank you. Yes. All right. Thank you.
All right. So here we have the illustration of what that normal response and what the elevated response looks like. So the parasympathetic is that normal response. It's how you are when you're calm in your everyday life. Constricted pupils, slow heart rate, constricted airways, your stomach activity is stimulated, your brainstem is sending those enzymes to digest, and all of your automated functions are happening. Whereas when you're in fight or flight, your pupils are dilated, your heart rate increases, your airways relax, your respiration tends to increase along with your heart rate as well. Stomach activity is inhibited. We don't have that digestion happening when we're in fight or flight because it's not necessary, which also could mean that if you just ate a really big meal, it's coming back and it's evacuating your body because it's not needed in that moment. Fight or flight really, really is about survival. And what do we need to survive in this moment might be secreting adrenaline. It might be having sweaty palms and feet in order to make us slick. Legitimately having different responses in our body to make sure that we're able to survive whatever this threat is. And this normal response to a survival need, the sympathetic nervous system, it takes over and it does exactly what it's supposed to do to keep you alive. And we can see this as a normal response to a trauma, to an event where we think we might be in danger, our lives might end. And it's also fairly normal for the immediate aftermath. So when we are looking at what is the difference between acute trauma and post-traumatic stress disorder, some of this is we understand that we're supposed to have specific bodily reactions, specific cognitions, specific symptomology that might be consistent with PTSD while we're in that acute trauma time frame. And those things should progress and get better over time in order to we're processing, we're moving forward. It's when we get stuck that might transition into more of a what we would hallmark of PTSD presentation. So the real differences between the traumatized brain and the normal brain really is that limbic system. It's the emotional regulation. And it's what we do in that period of time immediately post-trauma to prepare ourselves and to process and to understand more about what we're experiencing that helps us to build that resiliency and to ideally prevent post-traumatic stress disorder.
I'd like to just take note that every time I go to click to the next slide, it bounces me back to the previous. Don't know why that's happening, everyone, but thank you for kind of walking through that with me. Sorry, Amanda. I think it's going to continue throughout the duration of the presentation with the two screens. So let's land on our resilience meter. Thank you. Question, before we break out into our break for the morning, how resilient do you think you are? Scale of 1 through 10, and just drop your numbers in the chat. There's no right or wrong. How resilient do you think you are? Let's check in on your resilience meter, 1 through 10. 10 being the most and 1 being least. High scores already off the bat coming in here. Yeah. Wow. If we did a poll and did an ad and a sum of everything, it looks like we're probably sitting around a hearty 8. That's my quick observation, Amanda, just looking through what the chats are here.
Yeah.
Yeah, makes sense, everyone. So the assumptions are correct. We are among kindred spirits. Okay, thank you so much. We're going to move into a brief break. It'll be 10 minutes. Okay, so 10 minutes on the clock now. Callie's going to jump in here and keep us on track. Excellent. Thank you so much. We did have a couple of questions in the chat. Not sure if everybody can see them. I think it's just you and I, so not going to disclose who asked or why, but I think it's important for maybe us to just touch on the questions because they are pertinent. And if somebody has the question, then maybe other people do too. And so the one question that came up, and I'll be general about complex PTSD and how that factors into resilience. You know, what are kind of the best courses of treatment when trying to increase resilience when coping or dealing with complex trauma, but not just complex trauma that has existed, but complex trauma that actually may currently exist. And so I treat this as if I would a care plan for anybody, whether it's my self-care plan or our care plan for a client or a patient. And that would be to really get into the details. I'll kick that over to Amanda. She is the trauma-informed care expert here. But maybe the first approach in the clinical mindset would be towards stabilization. So always want to stabilize whatever those circumstances are around the traumatic event. How can we create safety and security during that time, whether it's to remove a person, individual, or obstacles that may be in the way or causing that destabilization, if possible. And if they're trauma impacted or from the past, then how do we then create psychological safety, which is a tool that we're going to talk about in a few minutes here. And then maybe working on some grounding techniques. But in complex PTSD, research does tell us that multiple tools like DBT or EMDR or internal family systems therapy are going to be the pathways which help to build multiple interventions towards building that resiliency. It's not just one and done, as is nothing, right? The treatment plans and care plans are always going to be a pollination of mixes that work well for individuals, whether it's us as the clinicians or the treating provider or personal experiences or for others. We want to pick and pull and play with the things that maybe are going to work best and then put down the things that are not particularly helpful in that moment. Amanda, do you want to take a look at the next question?
I would love to. What are the ways that we can self-regulate in the midst of acute stress that we don't allow personal history of trauma to interfere? It's a great question. Really looking at how you're regulating, like in order to kind of minimize your response to things is the exact same as when you're in acute stress, right? The focus needs to be on that regulation piece, whether it's through deep breathing, whether it's through yoga. We're going to get into some of the other ways in this second half, but also how we separate really is that grounding, right? Separating from that history is reminding ourselves where we are in the here and now. So that can be grounding techniques that are, space related. I personally really love, there's a technique called look, point, name, and it is exactly what it sounds like. You look at a thing, you point to it, and you name it, and you just keep doing it. You keep doing it while you're in that space so that you're bringing all of your senses really into the space. And that mindfulness of where you are when you are can be really, really helpful in order to make sure that you're not going back into those prior experiences and you're experiencing the here and now.
Oh, love that. Thank you. A lot of stuff coming up in the regular chat too, Amanda, just FYI. Okay, so let's get into it, right? What are the tools? So paraprofessionals, the underdogs of healthcare, risking safety at what cost have we become desensitized? Well, We last took a poll here in the chat of what's your resilience meter. And I'm not saying resilience is desensitization. Let's not get that conflicted. But if we are going to talk about resilience and desensitization in the same conversation, that a part of it, and somebody did mention it, it's a double-edged sword. It does work in our favor. And I would say on average, we've probably scored ourselves as a group a total of 8 on the resiliency meter. So that's kind of where we are. Who are the first in line? And we have touched upon this, but the most protective factors we need to circle around and be aware of are the folks who are the first responders. So the people who have the continuous working relationships with those who are listening firsthand to stories of trauma, helping our clients work through that trauma, frequently may be exposed to microaggressions. And I was going to ask the chat, what are some examples of microaggressions, or what is a microaggression? I'm not sure we have time for all that in this particular format, but the microaggression could be just somebody, and I know that there has been conversation here, just having an individual, a person who we're serving, yell, whether it at us or in the milieu or around us or in the community, just hearing that scream, and maybe it is towards us, or hey, you coming down the hall. In most normal circumstances, you're probably not having people yell, hey, you down the hall. Is that a microaggression? Maybe not, but the behavior of it could be. How the yell is perceived. A microaggression could also be a person's posture or a stance while in your presence that make you feel a little intimidated. So these are all different tactics that I think as healthcare professionals, we become a bit accustomed to over time and think that this is the norm, where in fact we are working in an abnormal environment. Just want to put that out there, put it in the context. When we are at home and going about our daily business, if there was a strange person who approached you with a threatening stance, you shouldn't say, oh, can I help you? Let me help to de-escalate you in this moment. Is there something that you need? You probably should walk away, right? So, but yes, these acute care settings are really the individuals that we're talking to here in that first line of exposure to the trauma. And of course, the second-hand group are the triage and assessment individuals. So they're getting that first review of the charts, the history and physical, up close and personal. We are assessing for suicidality and safety risks. We're helping to collect history and data, psychological data, medical data. Our best practice and our best approach to this is going to be, again, the trauma-informed care response, non-judgmental. Let's be inquisitive. Let's practice some motivational interviewing. We want to be inquisitive beings, not defensive beings. And as we practice those skills, we in turn become more resilient and help develop stronger boundaries. Because it is known that, unfortunately, if you are in this practice, this is a helping profession, it is healthcare, and there is a high risk and high rate of violence within healthcare, just by nature of the role, whether it is intentional or unintentional. Okay. And this is where most microaggressions and threats do occur, specifically within the behavioral health realm. And our stance is we take all threats seriously. I would recommend that as a group, you maybe think about taking that sort of stance as well, whether you personally believe it's an empty threat towards you or others or themselves. If we don't take it seriously, then we're not acting in the best interest of the individuals that we serve. And then that is how we have poor boundaries and we decrease our resiliency. We want to be resilient by having a good offensive, a good toolbox full of skills to be able to help ourselves prevent harm to others. And that's the way to best treat that. So hospitals and acute care settings. I also want to call out that the community as well. I saw a lot of people in the chat talking about their community crisis intervention teams. Thank you so much for having that arm and that functionality. We do need you. We need that community involvement. These are the typical people who we see. Anybody who's on the 8 or 12-hour shifts, 40 hours a week, think about it. How many days in the week are you constantly helping others and exposed to these sort of risks or occurrences within the community? It happens all the time, whether it's mild or moderate. So the likelihood of harm is high, whether it's physical, emotional, mental, financial, etc. And we want to make sure that you are equipped with the things that you need to protect yourselves and protect others. A lot of good resources here, some publications, maybe a bit dated from 2018, but nonetheless would recommend for anybody here on joining us today, if you request these slides, you'll have this and the resource packet as well. So what do we do? What's our response to all that? Okay. Well, let's talk about psychological safety. I certainly did not coin the term, but I did mention it in the first portion of today's presentation. And so I will read the little bean in the corner here, that psychological safety at work does not mean that everybody is nice to each other all the time, but it means that people feel free to brainstorm, that there is a safe space where people's voices can be heard. People can share their thoughts openly and challenge the status quo, share their feedback, and work through disagreements together and know that they are a valued team member. And certainly at Promises, we want to make sure that that is front and center in everything that we do. And there's always opportunity for us to continue to build upon that. And so we want to make sure that we are having good psychological safety and resources to support a collaborative workplace. Let me go back a slide for a moment because one of the tools here has been updated. So the psychological safety climate, the PSC12, there is a abbreviated version of this, which is a 4-point questionnaire. And the underpinnings of the PCS4, or the shorter tool, really talks about workplaces' response to managing a commitment to psychological safety in the workspace, management for priority of psychological safety, organizational commitment, and participation. So just kind of want to toss that out there. For those of you who do want this slide presentation, you will get a snapshot of another tool that can be used for any discipline, whether you have a workspace of 2 or more. This is a great tool. You kind of get somebody's input as to how psychologically safe they feel as though the team is. What is the team respect? Are they learning? Are they learning from you? Are we learning from each other? Are new ideas welcome? It's kind of like a meter again. You want to check the temperature in the room. Love that. Let's check the temperature in the room. And it's a quick evaluation, 11 questions here to just kind of agree, strongly agree, disagree. And it can tell us, how well we feel safe and heard in any kind of situation, because these things also build the resilience. Being heard builds resilience, and it helps when we're talking about healthcare's self-care. That's for us, everyone on the call. So here are the techniques to decrease stress, improve your mindfulness to not only the frontline healthcare professionals, but those who are impacted all around. Think of the pebble. So a couple of techniques we're going to try today is going to be the box breathing technique. If this is new to you, fantastic. If not, take it a moment to just take these few little minutes of time back to yourself. So a breathing technique that we use is called the 4-count breath, or box breathing, and we'll practice this right now. So I'm asking if you are able to sit comfortably, hopefully wherever you are, you're able to sit or be upright in a comfortable position. You want to put your hands on your lap, keep them grounded to a place or a center point on your body. Maybe put your feet flat on the floor. Okay. Sit upright. Take a moment to pause. You're doing a good job. And we're going to practice the box breathing. You're going to inhale for 4 seconds. We're going to let our lungs fill up and our belly expand. And then the next directive I'm going to give you is to exhale for 4 seconds through your mouth or through your nose. And you're going to count slowly and empty those lungs. So that's the way that we'll practice. And now we'll roll into it. Okay. Take a deep breath, everyone. Inhale for 4 seconds. Count it in. And exhale. Repeat. Inhale for 4 seconds. Count it in. And exhale. 4 seconds. Let it out. I hope that 8-second exercise gave you a little bit of grounding and peace and joy in this morning. This is something that you can use personally and teach others. Thank you. And teach others. It's very simple. You don't have to be anywhere special to practice it, but it's a moment to reorganize and become more centered with yourself. This is a resilience building technique. When we talked about the brain, the amygdala, and all those different pathways of how to build it, this is one of those great ways. This is why yoga happens to be a great practicing tool for those of you who are able or willing to try to rebalance and to build that core strength, not only in the mind, but in the physical body and the being, mentally, spiritually, emotionally. One technique down. Next technique, meditation. This is a mindfulness check-in, being open and aware with ourselves. I like to say, talk to the person in the mirror. And for me, I talk to the lady in the mirror all the time. Okay? This can be a 3-minute or a 2-minute technique. You're just going to be practicing mindful situations to be aware of yourself and your surroundings. Can you look at yourself in the mirror and just be basic? Here's where I am. These are my surroundings. This is the immediate intrusive thought that comes to my mind. Be okay with it. Let it hang out or push it away. And am I okay with myself in this moment? Don't judge if the answer is no. And don't judge if the answer is, I don't know. Just let it be. Okay. What do I need to do to step forward? Talk to that person in the mirror and give yourself 3 moments in the morning. Just a mindfulness check-in. And if that doesn't work for you, at night, right? When you close your eyes at night, doesn't matter who's around, you are with yourself. It's a good time to do a little mindfulness check-in. Setting aside some time for ourselves throughout the day, making sure that we are engaging in the activities that we really do enjoy, because that's what fills our cup before we can fill somebody else's, of course. You know, it begins with us. And practicing these techniques every day are some of those core skills that, again, builds the resilience where we are enabled to run towards that noise with a full cup day in and day out. So kicking it over to Amanda, who's going to tell us all about how to train and be good trauma-informed care providers. Again, please pick up on these are paralleled experiences. So as you train others, you are training, you are teaching, and you are doing it yourself. You're on mute.
I realized, sorry.
Gotcha.
All right. So patients experience when activated, again, parallel process, right? But when people are activated, we referenced this a little bit earlier, they're not necessarily having the same context, clues. Their goals, their thought processes are all very cut off. And so once they're, no longer activated, they can have a lot of insight into, oh, right, this action that I took was not very helpful for me achieving my goals. For example, yelling at the nurse didn't help me to access my medications. Once the calm, rational part of the brain is able to take over, their understanding of that is much better. However, when they're in that mode of the limbic system has taken over, that's not what they're thinking, right? The consequences go away. So this is when we see people who are, taking actions that are not necessarily in their best interest, taking actions that are going to diminish their relationships, diminish trust in their relationships, all of the trauma responses that can happen in that time can have long-term negative impacts. So we want to make sure that when we are working with people who are experiencing that activation, we're trying to regulate them as quickly as possible so that their rational brain starts to take over again and they're not continuing to kind of dig their problems worse. Go ahead, Andrea. Thank you. So once we are able to think rationally, obviously CBT is super effective, right? When we are able to apply logic, get people to come to their own conclusions, shift their thoughts, then the feelings and behaviors follow. One thing that I find to be very helpful is when we're working with staff who don't have training on CBT, really kind of breaking it down into a really easy to understand exercise. And Andrea, I'm going to utilize you for this exercise. So, Andrea, when you were a child and you woke up and you saw snow on the ground, what did you think?
I'm going sledding.
And how did you feel?
Excited.
And what did you do?
Put on probably my socks first.
Fair, fair, awesome. Now, as an adult, when you wake up and you see snow on the ground, what do you think?
I dread it. And to be fair and transparent, we are in New England, Massachusetts. So just want to share that with the larger audience because we have folks from all over. And when we get snow here, it's beautiful on day one. And by day three, it's a hot gray mess.
Yes, yes. So, very different thought, right? And then the feeling that you have when, as an adult, you wake up and there's snow on the ground. What is that?
Dread.
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 And how might that impact your behavior? What do you do?
Miserable. I curse at the snow. I'm probably miserable. I'm less than a fantastic person to be around. And I think about the times where I wish it was summer.
Right.
Hmm.
Right. So very different responses, right? So when we are able to shift the thoughts, the feelings and the behaviors do absolutely follow. And the context for the different situations that help us to change the thoughts is critical, which is why we need to have that cortex online in order to effectively use CBT.
I have figured out how to move to the next slide at the end of our presentation. Isn't this fantastic? In the last 15 minutes, I
In the
understand.
last 15 minutes, amazing. All right. So when we are talking about interactions with others, right? We as humans, just in general, right? All humans, we all do it. We can make assumptions, right? And pain is invisible. We can't see the pain, the problems, the thoughts, the intentions of what a person is going through. All we see is the actions. And that can lead us to think very specific ways about the person's thoughts or intentions. However, when we're looking at a person's actions, there could be numerous reasons for an action that may not even occur to us, right? Because we're looking at that action and perceiving it and the assumptions that we make regarding the thoughts or the intentions, we're filtering that through our own perceptions. And our perceptions and the other person's perceptions are not going to be the same thing because it's built off of our experiences. So we can make erroneous assumptions about a person's thoughts and intentions based on the actions that they have. And while this is just a normal part of being alive, being human, it is something that we need to be cognizant of. We also need to be cognizant of the fact that the individuals we're working with, whether they be other staff or clients, have that same issue as well, right? They are also human. They are also only seeing our actions, and they can be implying thoughts and intentions as well. This kind of cycles back to what I was saying before with transparency and giving people the rationale up front. I'm not going to do this because goes a long way. It doesn't necessarily make the I'm not going to do this easier to hear. However, it can make it a little bit easier to move on from because they understand the rationale and why. All right. I pulled something from the chat earlier that somebody had shared, and I'm just going to sum it up, where this person shared that they had to do an assessment over telehealth and assist a patient with crisis over the phone. And they had to stop the assessment because of the crisis and the individual that they were assessing wanting to harm themselves. And this person identified that they really wanted to go into panic, but they couldn't. They had to remain calm, and they enabled, the assistance of their supervisor, and presumably it all worked out okay. However, the reason I highlighted that and I wanted to bring it up is because this is exactly what this is about, right? We are the people who have to be the professionals. we have to be the ones who are calm in the crisis. And that's not always easy, right? We all are, again, humans. And this goes to what our own experiences are and what we might be bringing to the table. So when we are the calm person, we're going to be able to bring that other person who is dysregulated back down and get them to be calmer as well. If there is a person that is dysregulated and we match that energy, then it's just going to rise from there, right? So when we are the calm person, we are able to manage our own uh, emotions in the moment. It helps that situation, but it's not easy. I don't know if by time wise, we probably want to skip the questions, but thinking about for yourselves, thinking about what brain state are you in the moment when you're in those moments, right? When you're in crises, and even when you're not in crises. And that goes back to that meditation piece and self-reflection. Um, Acknowledging what it is that you're bringing to the table when you enter the workspace. All right. When our clients are having a traumatic response, it can look like a lot of different things. It could be, that they're trying to access the nursing staff or the clinical staff repetitively. They're not showing up for their groups. They're trying to leave. They're cursing people out. Having a lot of anxiety about all these different things. And when we're seeing those responses, it can sometimes feel personalized, right? Especially the calling or yelling at staff or cursing staff out. Not to say that that behavior is acceptable, but also acknowledging that that behavior is based on trauma and based on the limbic system taking over for that person. So we want to pull back and acknowledge that the person's response is about them. It's not about us. Just because we are the target of a specific client's outburst does not mean that whatever they're saying is accurate. If a client is saying that I'm terrible at my job, well, maybe I am, but the client doesn't necessarily know that. Whether or not I'm terrible at my job is something that I need to work on for myself and with my supervisor, but it's not necessarily something that a client is going to be able to tell me accurately. So when we look at it like that, right, the logic dictates that this client doesn't actually know whether or not I'm good at my job. They know whether or not I'm getting their specific need met in this specific moment. And the rest is just exaggeration. So when I have that healthy detachment, I can look at it logically and have the more compassionate response to the person without making it about me. All right. So skills that we utilize to bring people back down to calm states. As we've said numerous times already, that context, the cortex, is cut off. So applying logic in those moments when people are dysregulated is not effective. So we need to do the bottom-up approaches instead. When we're accessing bottom-up approaches, it is all of those things that we've already discussed, right? It's breathing techniques. Somebody had put in the Q&A asking about prolonged exhale, and breathing retraining is a specific skill that is utilized in CR for PTSD. It's one of my favorites. It is one where you are prolonging your exhale, and it is very, very effective, not just for trauma, but for regulation purposes. And I'm not saying that it's better than any other breathing exercise, because ultimately the best breathing exercise is the one that you actually do and the one that you find helpful for you. And that is true not for just clients, but for all of us. So while Andrea may find that box breathing works really, really well for her, I'm works really, really well for me. And there might be, a 5-7-8 breather out among here, right? So when it comes down to it, the skills that work the best are the ones that we're actually going to use. And our bottom up approaches can look like a lot of things. Breathing is just one of them. Intense sensations can be a big piece, utilizing ice or a hot shower, relaxation techniques, progressive muscle relaxation could be one of those. Grounding, like we were saying earlier. All of these different things are the bottom up approaches that are going to help reconnect and access that cortex so that people have access to their logical brain again. And once they do, next slide.
There is a question answer. Yes, go ahead. Go ahead.
Once they do, then we can utilize that CBT, or we can also utilize other skills such as OARS. So OARS is a motivational interviewing technique. It stands for open-ended questions, affirmations, reflective listening, and summaries. And OARS is a really great tool to get people to come to their own conclusions because we're reflecting what they're saying back to them. We're asking open-ended questions. Open-ended questions are going to be vital to getting them to think about things. We all know we are hardwired to be resistant to change. It is just a human trait. We don't love it. It's not great. However, if that change comes from within us, we're much more likely to buy into it. So when we are giving an answer to somebody, that's not necessarily going to be where their buy-in is. However, when we are asking them open-ended questions and eliciting that feedback from them, reflecting things back to them, allowing them to come to their own conclusions, then they're much more likely to have buy-in and be able to move forward.
That's an excellent reflection. And Amanda, there are a couple of questions in the chat too that kind of speak specifically to what exactly is a trauma-informed care approach. And I think you've just set us up for exactly what that is. Some examples of trauma-informed care approaches are open-ended questions, the affirmations, the reflective listening, it's summarizing, not judging or making conclusions that have not been given to us by the individual. There's also a question here in the chat around, I think it's a really great question. How do we support a client who fears retaliation from a former physically abusive partner while in the midst of divorce pending legal charges? My first response to that is going to be safety. I'm looking, we're looking at the four walls of safety. I'm thinking of Maslow's hierarchy of needs in this moment. Where exactly are we at? Because psychological safety is a little bit too high to achieve in this moment because psychological safety has been broken for this individual. So I'm literally looking at what are the physical locations of this person? How do we isolate them from the abusive individual in this storyline? And then what are the protective community resources that may be able to be accessible to the individual during this time, right? We're talking about relational violence, domestic violence. So what are those domestic violence resources? Those would be sort of some of the resources I'd be interested in. And certainly here in Massachusetts, East Coast, Massachusetts, Rhode Island, New Hampshire, Vermont, there are strong domestic violence programs that are very protective of individuals experiencing domestic violence and will help to physically relocate even during those troublesome moments. But again, that's a specific question. Amanda, do you have any thoughts about that, how trauma-informed care approaches can best serve that client? Because I'm thinking of more social resources in this moment.
Right. I think that the safety is obviously the number one, like you said, acknowledging that when somebody is leaving an abusive partner, that is when it is the most dangerous. So definitely taking safety as absolutely paramount. And a trauma-informed care approach is really going to be around empathizing with that individual based on what their experiences are. Not just, being non-judgmental, but really trying to put yourself in those shoes and having empathy for what exactly this person is going through in this moment.
And by the way, for the person who did ask the question, thank you. Also note that our our peers here in the community are also responding to other types of interventions that may be helpful for this particular case scenario that you've set up for us, including EMDR, chakra meditation, Maslow's hierarchy of needs, IPV empowerment, Erickson's, yes, very helpful. Yeah, it sounds like there's a lot of opportunity here for some cross-pollination of sharing of disciplines and resources. So appreciate all those resources going out to folks. We are at the 2-minute mark, and we are at that point in the presentation where we're going to say thank you so much for being here with us today. As Callie had mentioned, Amanda and I are both with the Promises organization, and we are currently at Washburn House, located in central Massachusetts. We provide a full continuum of care and treatment for individuals for seeking recovery purposes from substance use, primary, and then behavioral health, offering detox level of care, crisis stabilization, long-term residential outpatient services, and our alumni program. So essentially, somebody could walk through our doors on day 1 and then be part of our continuum year 5, 10, infinity, and beyond. So we appreciate all of you being here today. This is a community first approach. I'm going to pass it off to Callie. If you have any other questions, please feel free to put them in the question and answer box below, and Callie will take it home.
Thank you both so much. That was great. I wish we could have you every month. You were both awesome. If you want to go to that next slide, Andrea, I might have just a reminder for April's April's webinar. About on motivational interviewing. So April 24th, 9 to 11. You can see the place to register for that on our CEGO website. You'll see that in your attendee dashboard as well. As a reminder, in May, we do have our ethics webinar. We have one a year that's dedicated for your ethics CE credit. So if you need that, join us in May. If you have any other questions about our programs, about Washburn House, about Andrea, about anything with Promises, you can email me at pbhu@promises.com, and you'll see your evals are going to be in your emails as soon as this is over. So thank you all so much. You have a week to complete your eval for the CE. So just so you know, you have a week. Okay. Thank you all. Have a great weekend. We'll see you next month.
Take care.